And I wanted to start off by saying Dr. Leibold's group did a really fantastic article. And in order for us to kind of talk about my article, if you won't mind, I will give a little background on what Dr. Leibold's article kind of discussed. So his article compared the overall infection rate and upper respiratory and nasopharyngitis rate for each of the biologic drug for psoriasis versus placebo, and kind of tell the readers what to consider when advising them about either continuing or discontinuing the drug. So it's very nicely done because these infection rates are typically used as kind of a yardstick for the medication's potential to increase our susceptibility for infection, including the respiratory viruses such as the flu or influenza and possible COVID. So with our article, I wanted to start off by saying there's currently no data on prescribing benefit or risk of stopping or continuing immunomodulators and immunosuppressants. So what we did is, building on Dr. Leibold's paper, we dived deeper into the mechanism of action of the various immunosuppressants and immunomodulators that are commonly used in dermatology. And we tried to link them back to the known immune responses during the coronavirus infection, gleaning from the recently published data from Asia for COVID-19 and what we knew from the last SARS pandemic in the early 2000s. So we looked at a number of immunosuppressants such as the systemic steroids, mycophenolate mofetil, cyclosporin, methotrexate, etc., and immunomodulators like biologics that are targeting tumor necrosis factor, IL-17, 23, and various other targets, as well as phosphodiesterase inhibitors. So we try to assess a risk level for their use during COVID by categorizing them to low risk, moderate risk, or concerning risk. I do want to emphasize that these are theoretical links, and we really need actual data to prove their real risk. But you can imagine that it's quite hard to do, as we won't be starting immunosuppressants or modulators on a patient who's already sick with COVID. So we will probably have to rely on registry data. That is a really commonly asked question, both from our patients and from our colleagues and the community as well. So this is my opinion. I think it's really important that we risk stratify the patient at their state, even when they are not on an immunomodulator or suppression, such as the comorbidities of metabolic syndromes, whether they have had a malignancy, and really consider their exposure risk, where they live, their occupation, and the exposure of their household members. We can only imagine that the risk of getting COVID is increased to various extent when the immunomodulators or the suppressants are added. So we want to also consider the risk of the drug, like what we said in the article. Some of them are theoretically low risk. It's probably okay to continue. Some of them are moderate to high risk. And depending on the patient, we have to determine on a case-to-case basis whether to discontinue or change to an alternative medication. I would say patients who are on moderate to high risk medications, as well as their baseline risk is higher to getting COVID, we want to consider whether there is an alternative treatment option. For psoriasis, for example, if a patient is on an immunosuppressive or a higher risk medication, the providers, we can discuss with the patient on switching to a more targeted or lower risk medication. And we have many options in psoriasis, but unfortunately that's not true for many chronic inflammatory diseases such as, say, hidradenitis suppurativa. I will also say, we want to evaluate the risk of people who are at much higher risk. For people who are on classic immunosuppressants, such as azathioprine or cyclosporin or mycophenolate mofetil, we want to consider switching them to a biologic if possible. But I do want to point out that one thing that's often underlooked is the consideration of the half-life of the drug. For example, biologics that are injected or infused through the intravenous route, they have much, much longer half-life, even though they're more targeted than something like an immunosuppressant or a small molecule inhibitor. The small molecule inhibitors and the classic immunosuppressants are dosed much more frequently. So while they may be more broadly immunosuppressive, they can stop and then their effect can wean off very quickly. So those are all the considerations that I go through as I'm evaluating the patient case by case basis.